Thank you very much for having me, and thank you for sticking around for the last talk. So I'm going to be talking about common pediatric sports medicine injuries. I don't have anything to disclose. So it's estimated that 30 to 45 million kids, 6 to 18 years, participate in athletics annually. Nearly 3/4 of U.S. households have at least one child that participates in organized sports. And sports participation is more accessible with increasing variety. So there's increasing sports specialization, which is participating in one sport at the exclusion of others. And kids are participating in those sports year-round and also in overlapping teams and sports at the same time. And as we all know, everyone wants to get a college scholarship and go pro, but that's very hard to do. Over 1/2 of kids, 14 and under, who seek medical care for injuries are due to overuse injuries. We can see all sorts of different injuries. Most of those occur during practice, and over 1 in 10 will have an emergency room visit for a sports-related injury. And as pediatricians, you guys are seeing lots of sports medicine injuries. So what we're going to do is just talk about some of the common ones that we see, review relevant anatomy, and then discuss management, imaging, when to refer, treatment plans, return to play guidelines, and then we'll go over some injury prevention recommendations at the end. So I thought it would be fun to present these as cases. So it is springtime, it's baseball and softball season. So our first kid is a 14-year-old right-hand dominant male baseball pitcher who's got gradual onset of right shoulder pain for about a month. He's got tenderness over his shoulder, and he's got positive impingement signs. So our impingement signs would be Neer's test. So basically, if you passively internally rotate and adduct them and bring them up overhead, so you're bringing your arm near to your ear, and they have got pain over their anterior shoulder, that's a positive test. And then Hawkins test is they're abducted and then you're internally rotating them. So these things might bother this kid. So does anyone have any ideas about what this might be or what kind of things you might be concerned about? So what I would be concerned about would be possible rotator cuff tendinitis, some shoulder impingement, biceps tendinitis. As far as a rotator cuff tear, it's actually very uncommon for young children to tear the rotator cuffs. But the thing that I really think about is something called Little League shoulder. I've seen this called all sorts of different things. Proximal humeral epiphysitis, proximal humeral epiphyseal. Some people call it a Salter-Harris 1 fracture of the proximal humerus. And this is due to repetitive overhead movement. So we see this a lot in baseball players who are throwing the ball. That's why it's called Little League shoulder. But I see, softball players, I see a lot of swimmers that get this as well. Basically, they have to be skeletally immature. So we usually see these in kids ages 11 to 16. So I do typically x-ray these kids, and I get an AP, scapular, Y, and axillary view to evaluate their shoulder. And what you can see is sometimes you can see a little bit of widening of that proximal humeral growth plate. So you can kind of see that on the lateral aspect there. Sometimes you can see a little bit of sclerosis, but a lot of times actually x-rays look normal. So it's more a diagnosis, knowing their history, knowing where their pain is, and they've got tenderness on palpation over that proximal humeral physis. So treatment for these kids is going to be rest, and I tell kids it takes about 3 months to get back to physical activity. So that's really upsetting for a lot of people because they're in season and that's the end of their season. I get kids into physical therapy right away. And not only are we working on shoulder strengthening, but we're also looking at scapular strengthening, back strengthening, hip and core and lower extremity, because we want to have a nice, strong hip and core, because we want to be generating your power from your core. And when we get weak in those areas, we start throwing differently and altering our mechanics, which can kind of cause this in the first place. So we want to make sure we address all those deficits. And then once that pain resolves, we can get them back to throwing gradually. We have them do a gradual interval return to throwing program, and I have physical therapy help with that. And that's going to take a few weeks also to get them back to full play. So this is something that if you feel comfortable managing it, you can definitely do that, but also certainly refer them to sports medicine. So case number 2 is a 15-year-old female gymnast with right-sided low back pain. And she's had pain for a few months. It's been getting worse. It worsens with physical activity, specifically backward bending. So you can see she's doing all sorts of backward bends. And also it's bothering her a little bit sitting in school, but it improves with rest. So things that I would think about would be, muscular or mechanical back pain, sacroiliac joint dysfunction, but really you want to be thinking about a spondylolysis, or I call it a spondy for short. So this is a stress fracture of the pars interarticularis. It's the most common cause of identifiable back pain in active adolescents who seek medical care. And typically this is an overuse injury, so this is that repetitive extension that we think causes this injury, also some rotation as well, but sometimes it could be a cause of direct trauma, but that's a lot less likely. So our girl that we are talking about, so she's a typical patient where she's a gymnast, so doing a lot of backward bending, but also dancers, figure skaters, rowers, football linemen who are up at the line with their back in an extended position. But then actually we see this injury in all types of athletes, runners, soccer players. We almost always see this at L5, so 85 to 95% of the time it's going to be at the L5 level, 5 to 15% of the time at L4, and the other, it can be at those higher lumbar vertebral levels, however that's a lot less likely. Risk factors for developing this is a family history of spondy and then spina bifida. And so here's just a picture of the lumbar vertebrae, and so, basically, the pars interarticularis, and I apologize. There's not a pointer up here, is there? The mouse. Oops. Yeah. Oh, that's okay. So kind of right. So just below kind of those red areas, those transverse processes, so kind of just below that is the pars interarticularis, and that's the part kind of between those superior and inferior facets. And that's okay.
Okay. There is a pointer here. The trouble is the people online don't see what you're pointing at.
Okay.
So.
Thank you.
It was working. There it is. But you can't see it up there.
Yeah.
Okay.
No, that's okay.
Sometimes you can see it up there, sometimes.
So on physical exam, these kids are usually going to have tenderness and palpation, pain with lumbar extension, a positive stork test, which is what this picture is. This guy looks really sad, but it's a one-legged hyperextension test. And so you have the patient lift one leg up. Sorry, I can't go too far away from the microphone. Lift one leg up, and then I will stand behind them and have them bend backwards and see if that causes pain. Usually these kids are going to have really tight hamstrings, so just in general there's a link between back pain in general with tight hamstrings, but especially spondies, and usually they're not going to have any neurologic symptoms. So to be honest with you, there's actually a big variety as far as how people work these injuries up and also how people treat these injuries. So I typically start with x-rays, and I will get an AP and a lateral view. In medical school, we're all taught to get an oblique view because that helps us see the pars interarticularis the best. But actually in the sports medicine world, we're not doing that as much, just because usually those oblique views are not very helpful. And so they won't, so the risk of the radiation associated with that does not justify kind of getting those views. So we typically don't get the oblique views. And if we're clinically suspicious that someone has a spondy, because x-rays really can miss spondies. So I would say if you have a negative x-ray, that doesn't rule a spondy out. So if you're clinically suspicious, either treating someone like they have the injury or obtaining advanced imaging can be helpful. And so those options could be getting a lumbar CT SPECT, a thin sliced limited CT to the area of concern, which typically is going to be that L5, L4 area, or MRI. And so I really tell people to talk with your local radiologist to see what they feel comfortable reading, because people have different protocols and may or may not feel comfortable interpreting those. And so at the University of Michigan, we have a spondy protocol. And so, so basically it's a regular MRI protocol, and usually MRIs of the lumbar spine are really good at picking up disc pathology. So we do that, but then we also add in oblique sections to look at those L4, L5 vertebrae, and those can help show us if we see some edema there or a fracture there. But I always counsel my patients too that there's a possibility that we could have a false negative. So we may have a crack there that we can't see on the MRI. So it can be really tricky actually. So a lot of times MRIs do a good job, but if I'm still really suspicious, I'm gonna, even if their MRI is normal, I'm still gonna kind of treat them like a spondy. And so what that means is different depending on who you are. And so in general, the goals of treatment are to eliminate pain, get people back to activity, and prevent recurrence. It's a little bit controversial because some people will use big back braces, and so that's what this is showing a picture of. Typically in Boston, this is called a Boston brace because a lot of people in Boston use this, and they'll have protocols where people are wearing this for about 23 hours a day for multiple months. The way I was trained is that I don't use back braces very much unless someone's having a lot of day-to-day pain, but how I think of it is that we don't want to put someone in a brace, immobilize them, make those muscles really, even weaker, and we think that they're weak to begin with. So what I do is I have people rest from their physical activity and get them into physical therapy right away, and then we keep them in a core neutral position. So I really educate them on avoiding lumbar extension, and then we're going to be working on strengthening those core muscles up, working on our hamstring flexibility. And a typical return to play for this is about 12 weeks, but I really tell patients about 3 to 6 months to get back to activity, okay? So possible complications of a spondy is the spondylolisthesis. So a lot of people kind of use spondylolysis and spondylolisthesis interchangeably, but the spondylolisthesis is really, by definition, you have to have a bilateral spondy. So you've got a crack on both sides of those pars interarticularis, and then you've got an anterior, usually an anterior translation of one vertebrae on the other. So that's what this picture is showing us here. And so, that's not good because that's not going to heal back. That's going to kind of always be like that or potentially progress. And when that spondylolisthesis develops the highest, so it's uncommon to happen, but if it does happen, the adolescent growth spurt is a particularly vulnerable time. And obviously, if it progresses, you can compress the spinal cord, you can get neurologic symptoms. And so there's different grades of spondylolisthesis, grade 1, 2, 3, 4, and it's kind of divided up into like 25% of slippage. And so if someone's at a grade 2 spondylolisthesis or higher, or things are progressing or their pain's not getting better, this would be someone to refer to peds ortho, actually. So case number 3 is a 15-year-old field hockey player. While sprinting, has an acute pop and pain in her anterior hip. She's unable to continue playing. She falls to the ground, and she has trouble getting off the field. She comes into your office. Now she's walking with a limp. She's got pain with activities of daily living, and she's unable to get back to her sport. So things that I would be most concerned about would be an Apophyseal Avulsion Fracture. So this is a violent, forceful contraction of a muscle against an attachment at the growth plate. And this is a typical story we've got. She's running, she's doing something quickly, and then she hears and feels a pop and then develops immediate symptoms. A lot of times these kids can have a lot of swelling and bruising. And on your physical exam, they're going to be tender on palpation over the bony landmark that's been avulsed. And so we'll show that in the next slide. They can have pain with movement of their hip and manual resisted strength testing of that particular muscle group. And a lot of times they're going to be limping. So, apophyseal injuries. So, I always tell my patients, growth plates are, kids have growth plates. Growth plates are cool. It's where new bone is being formed. But growth plates are weak spots in the chain, and so those are areas that are prone to getting irritated. So, at the top there, we've got the iliac crest, which is where our abdominal muscles are attaching. Looking just below that, we've got the anterior superior iliac spine, which is sartorius. Which is a hip flexor, and then anterior inferior iliac spine rectus femoris, which is the attachment of one of the quad muscles. Lesser trochanter is the iliopsoas, where that attaches, and that's a hip flexor as well. And then your ischial tuberosity is where your proximal hamstrings attach. And then also on the right side, we've got a few open growth plates in the knee there. That are prone to getting irritated. So these are just, those muscle groups, that areas of attachment, and kind of common mechanisms of injury that can cause pain at those areas, and cause avulsion fractures at that area. So I will always x-ray these kids, and the views that I get are an AP pelvis and a bilateral frog leg lateral. It's nice to kind of have that theoretically normal other side to compare to, but in this x-ray you can see that that right ischial tuberosity is avulsed. So management for these, so if it's displaced greater than 2 centimeters, these kids should go to ortho, but it usually won't be, and so a lot of times we can manage them non-operatively. So I will put these kids on crutches, have them rest, and use ice, anti-inflammatory medications. Some of my colleagues will have people stay on crutches for a period of time, like 4 weeks or so, but I try to get them into physical therapy right away because one of the nice things about physical therapy is they can really help a lot with pain control, and so that can be helpful and then kind of get them moving a little bit. So we want to work on some gentle range of motion and some stretching, and then as they're getting better, we're working on strengthening and then gradually getting someone back to activity. So this is something that can also take a few months to get back. And this would be, like I said, if it's displaced greater than 2 centimeters, refer to ortho, but otherwise, appropriate to refer to sports medicine. Hip apophysitis is less dramatic than an avulsion fracture, but it's those same areas that can get irritated from that irritation from those muscle groups that are attaching on those areas. And so usually this is going to be more of a gradual onset of pain without a clear history of injury. And they're going to have tenderness on palpation over those bony landmarks. I will also always x-ray these kids because it's not uncommon that we've actually seen an avulsion fracture that was missed a while ago, so we can see that. And then you can manage these, but if they're not progressing, you can send them to sports medicine. What I typically tell people is that it's going to take, on average, about 4 weeks because we want that growth plate pain to settle down, and then we get them into physical therapy right away, and then they're going to be working with physical therapy to gradually get back to physical activity, which should be pain-free. So case number 4 is a 12-year-old male with anterior knee pain for 8 months. There's no specific trauma. It worsens when he's jumping, squatting, running. If he's kneeling or bangs his knee, that bothers him. And occasionally he's limping during or after physical activity. So things that I would think about would be, patellofemoral syndrome, patellar tendinitis, distal IT band syndrome, which is usually a little bit more lateral, but this case is going for Osgood Schlatter, which is tibial tubercle apophysitis. And so these kids are going to have tenderness on palpation over the tibial tubercle. It's going to affect kids ages 10 to 15, girls ages 8 to 13, and about 20% of the time it's going to be on both knees. You don't have to x-ray these kids, but if you do, on this lateral view, that's going to show you that open tibial tubercle right there, and they can look really irregular. In general, growth plates can look really irregular, and that's normal. So the diagnosis is made by you physically pushing over that tibial tubercle, and that causes pain. Sinding-Larsen-Johansson syndrome is like Osgood Schlatter's little lesser-known brother. Not as many people know about this, but this is basically the same thing, but just in a different location. And so this is going to be pain at the inferior pole of the patella, because there's a growth plate there too. So the same things are going to bother this condition as well. Again, you don't have to x-ray it, but if you do, sometimes you'll see a little calcification on that lateral view at the inferior patella. So for treatment for these, having them rest, modify their activities, ice, stretching, in particular their quads and hip flexors, patellar tendon straps can be really magical for these kids. So I always take an extra minute to counsel patients on how to use these. So that's that thin band that's right there. You tell them to put it over the patellar tendon, so kind of right below where the patella is, right above where the tibial tubercle is, and you want to snug it down, and that can be helpful a lot, or it can be very helpful. So as far as activity recommendations for them, so unfortunately these growth plates can be open for a few years, as you guys know, and so I kind of counsel patients, in a perfect world we'd love for you to have no pain, but if you have a little bit of pain, that's okay for you to participate. If you have a lot of pain or any limping with activity or compromised form, you should not be participating. So if your parents can tell that you are hurting out on the field, you should not be out there, because what I get concerned about is if you can't run, jump, cut, pivot, do the things you need to do out on the field, you're at risk for having another injury that could be worse, like tearing your ACL or something like that. So typically, management by general pediatricians is perfect. If they really are having a lot of pain, you can consider referral to physical therapy or referral to come see us in come see me in sports medicine. So case number 5 is a 10-year-old male who's a soccer player, and he's got heel pain. He's got pain with activity. It limps after he's playing, and he's tender to the touch over the heel. So this is almost always going to be Sever's disease, okay? So there's a growth plate right there at the calcaneus. Boys ages 10 to 12, girls ages 8 to 10, and this is a repetitive overuse injury. So, looking at this lateral view of the x-ray, which is similarly, you don't need to get x-rays on these kids, but if you did, this is what the growth plate would look like. You've got your calf muscles going down into your Achilles tendon, which attaches kind of right above that growth plate, and then your plantar fascia comes down and attaches at the inferior part of that growth plate. So a lot of times these kids have really tight calves, have really flat feet, and those can, can cause problems. A lot of times I see these in soccer players and football players who are in cleats that have metal or plastic cleats kind of right under there too, and all that impact can really irritate these heels. So kind of similar treatment and guidelines to our Osgood, Schlatter, and SLJ kids, where they're gonna rest, modify their activities. Heel cups can be really magical for these kids. So I like to have kids get heel cups that are soft and squishy and raise the heel up about 3/8 of an inch, work on stretching, and then same activity restriction. So you have a little bit of pain is okay, but a lot of pain or any limping with activity is not okay. And usually, you guys can manage these. Every once in a while, people are having really severe pain where I'll end up booting them, actually, for a short period of time. So case number 6 is a 17-year-old female cross-country runner who presents to your office for a well child exam. She has significant shin pain with running that is worsening, and she has not had her period for a few months, as she's in season, and she always loses her period during cross-country season, which we hear that a lot. So what I would be concerned about in this patient is obviously she's having shin pain. So is this someone, does she have shin splints? Does she have a more significant stress injury, like a stress reaction or a stress fracture? But then also her not having a period is concerning as well. And so what I would think about would be female athlete triad, which a new term that's been proposed is relative energy deficiency in sport. And so the 3 components of the triad are abnormal menses, decreased bone mineral density, and energy deficiency. And so on the left side, we've got the old proposed schematic, which is just that triangle, but the newer model is kind of showing this on a spectrum where we've got the disease state there on the bottom in the red, and then optimum health in the green. And so, not everyone has to have all of those 3 components to kind of, for us to be concerned about that. They can kind of have different parts of that. And also thinking about, the disordered eating as far as energy availability. So somehow there's a mismatch there where either people are not taking enough in or they're expending too much, and that can cause that mismatch. So it's really important to help try to identify this because the teen years are very critical for bone mass accrual. 90% of your bone mass is accrued by the age of 18. And studies have shown that if there's been an issue earlier on, those people may not ever kind of get the same bone mineral density of their peers. Also, the term relative energy deficiency syndrome is proposed to kind of include males as well. And I think one of the big take-home things is to understand that a lack of or a decrease of menses while training is not normal, and that's a concern, again, that there's an energy issue. And so this would be someone that, referring to adolescent medicine would be a great idea, and then sports medicine also, if there's a stress fracture or a sports injury. So this is the last case. This is case number 7, who's a 13-year-old male basketball player. He gets elbowed to the head and then falls and hits his head on the ground, so kind of like a double injury there. He develops headaches, dizziness, difficulty concentrating, difficulty sleeping, and is feeling more emotional. So I think we all know what we're concerned about here, and that's a concussion. So, there have been big changes in how concussions are diagnosed and managed in the last 5, 10, 15 years, and things are going to keep changing. Every 4 years or so, there's a group of experts internationally that meet. Their last meeting was in October of 2016, and they released guidelines in the spring of 2017. So the most recent definition of a concussion is that it's caused by a direct blow to the head, face, or neck, or somewhere else on the body that transmits that force to the head that causes symptoms. And those symptoms are a rapid onset that are typically short-lived, and they resolve spontaneously. A concussion is more of a functional disturbance, so as we all know, we're not going to see any changes on our MRI, CTs. It's more based on how someone is feeling, acting, and what they're reporting to you. So there are 4 main domains in which concussion symptoms fall. And so I just wanted to go through kind of what I do in the office for them. So, in obtaining your history, obviously finding what's the mechanism of injury, what happened, what signs and symptoms are they having. And I actually like to use, there's a post-concussion symptom questionnaire kind of checklist that's on the bottom right-hand corner. There's the SCAT-5, which is an addendum to that most recent concussion consensus statement, and that goes through a list of 22 different symptoms, and you can rate symptoms on a scale 0 to 6, and you have kids rate them within the past 24 hours. I think that's kind of nice because I have them do that actually every time they come and see me in the office, and it can kind of help trend their symptoms. If I have a patient that's really anxious, you have to be careful because you want them to be fixated on these numbers, but sometimes it can kind of give a trend and kind of tell you which symptoms are most bothersome to them, to kind of think about what you might be able to do that might be helpful for them for their treatment. Also finding out, is this someone who's had multiple other concussions before, or this is their first concussion, and what their previous recoveries were like. So is this someone who's historically taken multiple months to get back to normal, and did they get back to normal after their last concussion? Also, do they have any underlying comorbidities such as ADHD, migraines, learning disabilities, anxiety, depression? I like to say the concussions kind of play dirty, so sometimes if you have those things underlying, those symptoms can get exacerbated and cause more difficulty. Then on your physical exam, looking at their head and neck, signs of trauma, looking to see if this is someone, if you need to make sure they don't have a fracture in their neck, which hopefully is not the case, but a lot of times kids will get cervical strains, and those can be problematic and cause and contribute headaches, so sometimes some neck physical therapy can be helpful for them. Doing a good neurologic exam, which is usually going to be normal, and then also doing a vestibular ocular assessment, so looking at their convergence, looking at their eye movement, seeing if this, there might be some underlying, or not underlying, but there might be some vestibular dysfunction that could benefit from vestibular therapy, and also looking at their gait and balance. So the picture on here is a picture of the BESS, which is the balance error scoring system, and so this is something that we do in the office where we just have kids hold 3 different poses for 20 seconds with their eyes closed, just to kind of get a sense of what their balance is like. So as far as management, so in the past we used to, tell people go lay in a dark room, don't do anything, don't go to school until everything's all the way better, and don't interact with anyone. And so we've come to find out that that is not very helpful and likely can be harmful to our kids. And so really, although it's important to kind of rest in those first 24 to 48 hours, we really want to get people back to their normal life as much as possible. But I tell people to kind of let symptoms be their guide, right? So if you're doing something and that makes you feel worse, that's your body's way of saying, I probably shouldn't be doing this. And also focusing, just like Emily talked about, good sleep hygiene is really important as well. So, cognitive and physical rest are the cornerstones of treatment, but again, trying to get people back into their normal routine. So while it's important to, avoid things that are bothersome acutely, and they should be avoiding screens if they're bothersome, but as they're getting better, making sure that they're able to still kind of stay connected with their friends and with their social networks, I think is important. And then also giving them a letter to help with accommodations for school. And so then they can, I always tell people, make sure that you're communicating well with your teachers, with your guidance counselors, parents, and we just want to try to maintain academic success for these kids and giving them modifications that are appropriate and accommodations. So from a physical activity standpoint, so initially they should be resting and not doing any strenuous physical activity. But a lot of times if I see someone in the office who's had symptoms for about a week or so, I like to kind of get them moving a little bit, and so usually I have them get on the stationary bike. And so with our multidisciplinary clinic, they're actually seeing a provider, and then they have an appointment with our athletic trainer in the office. So we bring them to the gym so we can have them work out, put a heart rate monitor on. We can have them get on the stationary bike, and then as they're progressing, do other activities, and especially sports-specific activities. But even when they're home by themselves, doing a little bit of physical activity and kind of gradually increasing that, we think can be helpful. And then once they're completely asymptomatic, we have them officially go through the return to play protocol, which you guys are, I'm sure, familiar with. And I've got one slide on that in just a second. I think these are good resources. The AAP has recommendations on sports-related concussions and also returning to learn. And then I like this. This is from our clinic, we call it the brain protocol. So this is like a visual way of looking, of guiding people to get back to activity. So I tell people that everyone kind of starts on that left side of the steps there. And then ideally when they're 100% back to normal for at least 24 hours, we have them get on that first step, which is stationary biking. If they're doing well, don't have any symptoms during that, or in the next 24 hours, they can progress to the next step and so on. Then right before they get to that last step of no restrictions, they need to be medically cleared. And in the state of Michigan, an MD, a DO, a nurse practitioner, or a physician's assistant needs to be providing that clearance. And so for our high school athletes, there's a Michigan High School Athletic Association clearance form, and this is what it looks like. So a lot of times you'll have kids coming into your office that have these, and they want you to sign it. And this should be signed after they've gone through that protocol, and you're clearing them without restrictions. So as far as injury prevention, sorry, I've got 2 more slides. The AAP released recommendations in 2007, and what they recommend is taking 1 to 2 days off per week of sport-specific training, taking 2 to 3 months off of a specific sport per year, and that weekly training should not increase more than 10% per week. And so we call this the 10% rule. It's painfully slow, but we think it's a safe way to get someone to start a new activity or get back to activity. Ideally playing on 1 team per season, and then really sports should be fun. So I would say this is ideally what people should do, and almost nobody does it, which is not ideal. But in 2014, the AMSSM provided recommendations, and what their statement said is that prior injury is a predictor of future injury. It's important to evaluate females for menstrual abnormalities, making sure that parents and coaches are educated on age-appropriate sports readiness and goals. Early specialization may not lead to long-term success. So we all hear, stories about Tiger Woods, who started golfing at age 3, and so everyone else wants their kids to be playing a particular sport really early. But really, we think sports diversification can be helpful to help prevent overuse injuries and burnout. So in conclusion, we're seeing more injuries because there's more increased sports specialization, we think. And then young athletes are more prone to particular areas because of those growth plates. It's always appropriate to refer to sports medicine, so at any stage, feel free to refer patients. It's nice because sometimes we get a little bit more time with patients, can counsel them on returning to play, and coming up with specific plans. And then as far as x-rays, I just wanted to include these because these are my the views that I typically get, and just notably the foot and ankle. Our default is to get non-weight-bearing views, but I typically get weight-bearing views because we can see what those joints look like with you bearing your weight on there and kind of walking, because that's how you live your life. And then I included a few additional cases that obviously we're not going to go through, but one other take-home point is that a knee effusion in a young, healthy person is not normal and always warrants further investigation. Okay, so you have to think about, is there a ligamentous, cartilaginous, osseous injury? Is there arthritis or something else that can be causing this? And then the sports physical is a great time to screen and ask about anything that would make you concerned. I just wanted to give a shout out to my friend Rebecca Northway, who's a colleague of mine and helped with part of this presentation. These are my references, and that's my contact information. So thank you guys for sticking around.